wrong screen that you're getting, isn't it? Oh no, are you getting, which screen are you getting there, Michelle?
Yep, that looks all right. It looks like the title.
Oh, you got the title on. Okay. Sorry if I sound a bit funny. I think all the smoke and perth has kind of made my voice go a bit sort of raspy. So thanks, Michelle. So yeah, I'm presenting my PhD findings on satisfaction after total knee replacement surgery. My primary supervisor is Anne, and my co-supervisors are Pete O, Sam Bunsley, Peter Kent, and Michelle Dowsey. So before we begin, I'd like to acknowledge the Whadjuk people of the Noongar Nation as the traditional custodians of the land where I'm presenting from today, and to pay respect to Noongar elders past, present and emerging. So before we begin, I'll just give you a bit of an overview on what we're going to cover today for my PhD. So we're just going to begin with a short background to patient satisfaction and then lead into the first study, which was a systematic review. Following this, we'll talk about my first qualitative study of patient satisfaction 1 to 2 years post-total knee replacement, and then the follow-up qualitative study for that, which was conducted a further 2 years from that study. And then finally talk about the last piece of work I did, which was qualitative evidence and practice. And then we'll just discuss the findings. So before we begin, the background. So obviously with any patient that has a total knee replacement, we want them to have a meaningful benefit from the surgery. And typically we measure that with patient-reported outcome measures such as pain and function and patient satisfaction. So I'm pretty sure you're all quite familiar with patient-reported outcome measures. We typically use the WOMAC, and we give this to patients before their total knee replacement and then compare that score to their post-total knee replacement WOMAC and apply that change to WOMAC-ORSI criteria to define if someone's been a responder or a non-responder to the knee replacement. On the other hand, we have patient satisfaction. So patient satisfaction we use to capture the patient's appraisal of the intervention, and it's become very, very popular since the 1980s because it's been considered quite a simple metric to get a patient perspective. But because it's sort of proliferated so rapidly, it's resulted in a very broad variety of satisfaction questionnaires and quantification methods. And these can kind of vary from general satisfaction to satisfaction with aesthetics, with function, or equating it to other constructs such as expectations or willingness to undergo the surgery again. So there's a lot of lack of standardization considering all these three things, and due to this lack of consistency, it's very difficult to know what we're capturing from patient satisfaction questionnaires. So despite the measure of satisfaction being quite underdeveloped, there's been quite a bit of research trying to predict satisfaction after total knee. So maybe looking at these would give us a little bit of a clue to what's influencing satisfaction. Although there's been, a numerous amount of attempts to predict satisfaction, the most popular have really been fulfillment of preoperative expectations and psychological factors. So fulfillment of preoperative expectations has probably been the strongest theory as a determinant of patient satisfaction, but it's actually shown to be really inconsistent in the literature. So some studies show a really strong correlation between fulfilled expectations and satisfaction, whereas others don't. However, preoperative anxiety and depression has been more consistent in predicting dissatisfaction, but that still needs a bit of further work. So how does satisfaction relate to clinical outcomes of pain and function? So intuitively, we would think that people who have a good outcome from a knee replacement would report satisfaction and vice versa, but this is not always the case. We know that some people have actually quite meaningful improvements in pain and function, but report dissatisfaction. And some people have continued disability and pain and report being very satisfied from the knee replacement. So that leaves us being a bit confused about what satisfaction is actually capturing when we've got these kind of outcomes. So what does this mean overall? So we don't really know what it means when a patient indicates they're satisfied or dissatisfied after a knee replacement. And this is quite important because we think about 30% of people are dissatisfied after a total knee replacement. We don't know what this means, and that represents about 20,000 people per annum in Australia. We don't really understand how it relates to clinical outcomes. So this risks misleading clinicians, policymakers and patients to the potential benefits of a total knee replacement. So what can we do to try and understand patient satisfaction? We know there's been a lot of quantitative studies on patient satisfaction, probably from our knowledge over 900 studies that we've retrieved from literature searches. But to our knowledge, only 4 qualitative methods have been used to understand this construct, and 3 of them have been on process factors, such as the hospital experience or the food they get at hospital, something along those lines. And there's been 1 descriptive study on dissatisfaction after knee replacement, but this hasn't really been integrated into like a theoretical model of satisfaction. It's more just been a description of processes. So this led us to our first study, which was a systematic review of patient satisfaction after total knee replacement. So in this, we tried to see if we could get an estimate of satisfaction and dissatisfaction after total knee, and see if there's any content validity in the satisfaction questionnaires. And content validity really relates to whether patients have been involved in the development of the questionnaire, and that would give us some idea around what it means to the patient if there has been evidence of that. So I'm not going to talk too much about the methods of this study, but it has been published in Osteoarthritis and Cartilage if you'd like to access it. So to begin with, we found that we couldn't really get a full estimate of satisfaction because there were too many different constructs that were measured. So overall, there are 8 different satisfaction groupings. So satisfaction overall, satisfaction with the operated knee, with function, with pain relief, symptom, aesthetics, surgery, and composite scores, different components of satisfaction. There were 9 questionnaires used. 33 studies used a single item without origin to a questionnaire. 1 used a composite score without origin to a questionnaire, and satisfaction ranged from as high as 99% to as low as 39%. In terms of content validity, just a quick recap on what that is. So content validity is, according to the Cosman group, is the most important measurement property of a REPROM, and it reflects the degree to which the content of a PROM is an adequate reflection of the construct to be measured. So Cosman's actually created an assessment process to test content validity, because that's how important they consider it. And importantly, this assessment is based around whether there's been patient involvement in the development of the questionnaire. So there are 3 key steps in this assessment, and it starts with seeking whether the PROM has a development study, and then it looks for any specific content validity studies if they exist, and then content validity is assessed based on these 2 studies if they exist, as well as the rater's perception of the PROM, so mine and my supervisor's assessment of the patient-reported outcome measure. So what we found was from the 43 studies, 15 of them provided citation in support of the satisfaction instrument. And of these 15, 15 representing 6 instruments, so 9 studies representing 6 instruments had a citation of a PROM in their for their development study. 4 of these were excluded though, because 2 were not assessing satisfaction and they're more assessing symptom state. And the other 2 were excluded because 1 was designed to be completed by the surgeon. So the surgeon decided if the patient was satisfied, and the other 1 was actually designed for the hip. So that left us with 2, the New Knee Society knee scoring system and the self-administered patient satisfaction scale. But both of these failed content validity because they had an absence of patient involvement in the development of the PROM. So there was no evidence of content validity in any of the satisfaction questionnaires used after knee replacement. So the key points from the study where there's a lot of heterogeneity in the satisfaction measurement tools, we probably knew that already. So it wasn't possible to create a full estimate of satisfaction. Importantly, there was an absence of content validity. So we're not really sure how patients are interpreting this questionnaire or what is being captured by them. So that leads us to our first qualitative study, where to kind of fill this gap, we wanted to understand what it meant to be satisfied 1 to 2 years after knee replacement, and to investigate the factors that influence satisfaction levels 1 to 2 years after total knee replacement. So this study has been published in Core. So to do this study, we used constructivist grounded theory, and I recruited my participants from St Vincent's Hospital. So I was quite lucky. I got to spend almost 2 months in Melbourne doing my data collection. And I did one-on-one interviews with all the participants, and I asked them what it meant to be satisfied, and we sort of explored different components of satisfaction as well to understand what was influencing it. So what does it mean to be satisfied? What we found was satisfaction, the meaning of satisfaction depended on whether the person was satisfied or not. So people with high satisfaction conceptualize satisfaction as an improvement in pain and function, whereas people with low satisfaction conceptualised it as a complete resolution and restoration in pain and function. And what influences satisfaction levels? This was presented in a conceptual model which comprised of 3 key pathways, 3 key mechanisms, as well as thoughts, feelings, social and contextual factors. I'll just walk you through those findings now. So just orientating you to the blue circles, this is 1 year post-total knee replacement. So if patients had reported no or minimal ongoing symptoms or functional limitations, they were considered a full blast pathway and had a direct pathway to being very satisfied or highly satisfied. However, if a patient reported ongoing symptoms or functional limitations, this could go one of 2 ways. So in this pathway, which is the glass half full, they could end up being satisfied in the presence of positive thoughts and feelings like self-efficacy and acceptance, optimism, and positive social and contextual factors like positive family support, a good relationship with their surgeon, and social participation. And importantly, the influence of the 3 key mechanisms in this large green box to the right. So the first mechanism is a recalibration of symptoms. So they could have pain, but if they were exposed to other people that had pain, they might think that their pain was maybe less severe than other people, or maybe it was normal to have pain. The next mechanism is a reframing of activities. So maybe they went into the total knee replacement thinking they would be able to do all these really cool things afterwards, and then realised their pain and function didn't allow them to do that. So they either found new activities they enjoyed or kind of modified the activities that they wanted to do. Lastly, they'd have a non-volatile conceptualization of symptoms. So if they did have symptoms, the understanding of it was non-threatening. So that might present as attributing it to a bit of muscle weakness or just not being bothered by having pain at all. Or they might just say something like, well, it's only pain, I'm okay with that. In the opposite direction is our glass half empty pathway, and they would be less satisfied. And this happened in the presence of negative thoughts and feelings like catastrophizing and worry, and negative social and contextual factors that might be a lack of support at home, a negative relationship with their surgeon, and a lack of family support, and importantly, the negative influence of the 3 key mechanisms. So they might not have a recalibration of symptoms. They might feel like everyone else's outcomes who've had a knee replacement is a lot better than theirs. Therefore, they can't be satisfied. They might not be able to reframe their activities. So they might just be really hung up on the things they can't do and have not found ways to find new enjoyable activities or modify their activities. And lastly, they had bothersome conceptualizations of symptoms, and this was often quite fear-driven around problems with the actual quality of the surgery, feeling like their prosthesis had been put incorrectly, or there was nerve damage, or something along those lines. So it was quite fear-based beliefs. So key points: we know that dissatisfied patients want this resolution in their problems. So patient education before the knee replacement is really important. We need to let them know there is a likelihood of symptoms and functional limitations post-operatively. It's also important to educate patients about alternative treatment pathways. So this might remove the belief around knee replacement being the final and only option. And as you can see in the quote to the right there, I asked participant 17 if he was given any alternatives to a knee replacement, and he said to me, well, I don't know what alternatives are there. Then he laughed at me and said there's no other alternatives. And this was a very strong narrative in all of the participants. They just didn't believe there's any other options than having a knee replacement. Importantly, the conceptual model shows a lot of modifiable factors to help people be feeling more satisfied after a knee replacement. So we can use this as clinicians to help our patients. And this should obviously begin by positive communication techniques, so we can forge that good therapeutic alliance. We should then ask our patients about their ongoing symptoms and functional limitations, how it's affecting them and why they believe they have them. We should target rehab to improve symptoms and functional limitations, because that's obviously the entry pathway to being dissatisfied. So we can do some kind of GLAD style program for them that might be quite effective. Then we should try and identify the multiple barriers of satisfaction through the 3 key mechanisms. So that might look like addressing those negative or unhelpful beliefs about their pain. So an example of that is in the quote I have here. So I was talking to this gentleman about the fact that he's not playing golf anymore. And he said to me, well, you know, I don't want to twist, it would be bad. And I said, well, what do you think would happen if you tried to twist? And he said to me, well, they talk about infections and all that sort of stuff, so I keep safe. So that's a really obvious belief that we can target to reduce that fear avoidance behaviour. And then obviously we need to explore the influence of thoughts, feelings, social and contextual factors and address them within our scope of practice or refer on to appropriate allied health. So obviously clinicians can play an important role in this process for patients. This leads us to our second qualitative study. Oh, what's going on? So this study was really a confirmatory study of the study 2, the qualitative study. So we really wanted to test the assumptions of the conceptual model at a later follow-up, so 3 to 4 years post-total knee. So does the meaning of satisfaction change? Is satisfaction stable over time? And are those mechanisms still relevant? So this was still a constructive 3 study, and then we proposedly sampled from our sample in study 2. So study 2 had 40 participants, and so we tried to select participants that represented all aspects of the conceptual model so we could test it. So we ended up with 11. And for those 11 participants, I really closely reviewed their original transcripts to identify how they fitted in the conceptual model so I could kind of test it in the subsequent interviews. So did the meaning of satisfaction change? No, it remained the same. So people with high satisfaction saw it as an improvement, whereas people with low satisfaction saw it as a resolution. However, there was a strong kind of sentiment that dissatisfied people want the feeling of a normal knee, so a knee that hadn't undergone surgery in this study. Is satisfaction stable over time, and are the mechanisms or pathways identified in the previous study the same? So we'll go over whether people changed their level of satisfaction first. And they did. So one participant transitioned from glass half full to full glass because he reported no symptoms of functional limitation. And we had a swap in glass half full and glass half empty. So someone reported being satisfied, and someone who was originally satisfied reported now being dissatisfied. So we know that satisfaction levels can change at longer follow-up. And what about the influence of the 3 key mechanisms? So I might just reorientate you to what they were. So we have a recalibration of symptoms, reframing valued activities, and their conceptualization of symptoms. And what we found was that people might remain in the same pathway, so being glass half full, glass half empty, but their actual key mechanism can change. And I illustrate this with our half full group. Excuse me. So participant 2 in the glass half full group had no changes. She was exactly the same as her original interview. However, participant 18 was in the same group, but her mechanisms were different. So in her previous interview, she really expressed a strong mechanism of kind of reframing her valued activities, but this time her symptoms and functional limitations were very, very strongly linked to her comorbidities, and therefore she was satisfied because it didn't have anything to do with her knee. Similarly, participant 11 in his original interview described that he was satisfied because he felt like his knee was still healing and continually improving, and that was kind of his non-bothersome conceptualization of symptoms. However, in this follow-up study, he described his symptoms as non-bothersome because they were good for his age and adjusted his activities accordingly. And for participant 4, who transitioned into this group, so he obviously had a change in pathway and mechanism. He reframed his activities based on what was reasonable for his age. So we can see there that participants can kind of shift their reasons for satisfaction over time. Importantly, in this study, the influence of age or aging as a social and contextual factor came across a lot more strongly as a reason for persistent symptoms or functional limitations in their conceptualization of their symptoms and function. So I have a quote here from participant 11, and he's describing to me why he was satisfied. And he said to me, look, I'm 78, so I think I can get around really good for that age. I'm just a little bit disappointed in it, but I have to remember I'm nearly 80. So I suppose I have to be satisfied with it, wouldn't I? So key points, satisfaction levels can change at longer follow-ups at 4 years post-total knee replacement. And there is still potential for clinicians to help patients feel more satisfied at this point because the conceptual model, which encompasses a lot of modifiable factors, is still relevant. But we need to be cognizant of the influence of aging because we don't want our patients to over-attribute their persistent symptoms or functional limitations to the fact that they're aging when they could actually probably improve a little bit with some help. So lastly, we're going to discuss the qualitative evidence and practice, which is the final piece of work I did. And this came about because we noticed during the course of my PhD, there was a distinct lack of qualitative work in orthopedics. And there seems to be a lack of trust in qualitative data driven by a lack of understanding of qualitative principles. And we would see this in review processes where reviewers would apply quantitative concepts of rigor to qualitative studies, which obviously doesn't work. Despite this pushback, though, there was quite a bit of interest in my first qualitative publication in Core. So on Twitter, there was quite a bit of international interest. The article was the second or third most popular article from Core last year, and also attracted an editorial from one of the editors from Core. So we decided to write a 5-part series that really described the foundations or the fundamentals of qualitative research in lay terms, and how this research is clinically helpful and useful, and to also provide guidance for the appraisal of qualitative research in orthopedics. So to do that, I developed a metaphor centered around building a house. So it starts with foundations, and then you have your concept for the house. It might be a family home or a beach house. And then you create a building plan which complements the concept, so it matches the idea of, say, a beach house. And then you choose tools and materials which match that building plan. And then we do a safety check at the end to test the structural integrity of the house. So in Qualiland, our foundations are ontology and epistemology. And then we have our theoretical framework. So that's kind of like our concept for the study. Are we looking for the lived experience, meaning, something along those lines? And then we design the study to match that theoretical framework. Following that, we choose methods that complement our research design and theoretical framework. And throughout the study, in the end, we make sure that our study is trustworthy. So that's our rigor assessment in qualitative research. So each of these points are written in a 5-part series, and it's currently under review. This brings us to the end of my PhD findings. So what we know about satisfaction now is that a multifactorial fluid construct, and might be a better reflection of patient adaptability than anything else. We know that a lot of the factors that influence satisfaction are modifiable, so we can probably help people feel more satisfied by using the conceptual model. But we need to be mindful of people that are highly satisfied who are actually quite disabled because of that adaptability process, so they might not be seeking appropriate care. We also need to keep in mind that we're not finished helping patients after the first year. They can continue to change up to 4 years post-surgery. And for qualitative research, we know there's a lack of trust and therefore a decreased ability to explore the experience of orthopedic interventions through the patient's lens. So we're hopeful that with an explanation of how to use qualitative research in orthopedics, we'll have more resources to inform biopsychosocial approaches to patient care. And I'd just like to acknowledge my participants, funding from my RTP stipend and the NHMRC funded Centre for Research Excellence, Opus CRE, the amazing team at Opus, and other authors that contributed to the research outside the supervisory team. And a big thank you to my supervisors who are amazing, and it just wouldn't have been possible without you. Okay, that's it.
Great, thank you, Nadia. We might just hold off questions at the moment, but if you do have any right now, you can always put your questions directly into the Q&A box at the bottom. We might just switch over directly to Michelle Tu. So if Michelle could turn on your audio and share your screen. I'll just give a little blurb about Michelle while she gets ready. So Michelle Tu is from the School of Population and Global Health at the University of Melbourne. Michelle's research aims to maximize the use of longitudinal data to better understand patterns of health outcomes and health service use. So the work that she will be presenting today will focus on how personalised medicine can translate to better health outcomes and longer quality of life in patients with total knee replacements.
Great, thanks, Michelle. So I hope everybody can see my screen and also can hear me.
Yep, all looking good.
Okay, great. So hi, everyone. Thanks for joining Nadia and I today at this particular presentation to present our work from our PhD research. So I've spent the last 3.5 years working as a PhD candidate with Opus and under the supervision of Michelle Dowsey and Peter Chong. So I'm really excited to share some of the work that I've done and also to hear your thoughts about my PhD. So during my candidature, I've worked across 2 unique areas, but distinct treatment populations as part of my PhD. So it's in cancer as well as in orthopedic surgery patients. And for today's presentation, I'll mainly focus on my research with OPUS, which is specific to total knee replacement patients. So I will start by giving you an idea of what the overarching aim of my PhD is. So the aim of my PhD is to demonstrate the usefulness of real-world longitudinal data in health economics research and evaluation, and to make contributions towards advancing economic evaluation methods in an effort to support better medical decision-making. All of these, which I hope will contribute towards improving patient outcomes, delivery of care that is of better value, and also in ensuring healthcare sustainability, all of which are of importance in today's health policy agendas. So during my PhD, I've leveraged on a really valuable resource, which is the St. Vincent's Melbourne Arthroplasty Outcomes Registry, which we call SMART. In the studies that I've done conducted during my PhD, I used patient-level data collected over a 10-year period that is extracted from the Smart Registry. So it is a clinical registry that collects information both on clinical and patient-reported outcomes in patients that have undergone elective joint surgery at the St. Vincent's Hospital. So this registry, as we can see, it's a really rich source of data containing information on patient demographics, surgery details, and also follow-up data on patient-reported outcomes. So it is a valuable resource of real-world longitudinal data. So although the registry captured different types of joint surgery, the focus of my research was on total knee replacement. So one of the important measures captured within the registry are patient-reported outcomes. Patient-reported outcomes measures called, as we shorten it, called PROMs, such as WOMAC or Knee Society Score or the SF or BR12, are collected on patients and are commonly collected prior to surgery and sometime after surgery. And it could be also at various time points. So these measures actually capture patients' pain scores, functionality of their joints, and also their quality of life. The value of patient-reported outcomes is increasingly recognized as a way to measure or better understand outcomes of patients after surgery. And there is growing recognition in its value and also the need to integrate PROMs into clinical practice. So these measures are useful tools that could encourage patient-centered care and also to understand patients' outcomes that also matter to patients. For example, patients' quality of life and their functional outcomes that are particularly important to patients. And they can also help in facilitating patient engagement in a shared decision-making structure. So some PROMs have the additional benefit of capturing all the necessary information for cost-effectiveness analysis, which allows decision makers to compare the value of health interventions and to prioritize resource allocation. So these measures can also be used as a means of benchmarking providers or measuring the quality of care across different providers. So an example of this is that in the UK, this has been done for selected elective surgeries such as hip or knee replacement, where they publicly report these outcomes every 6 months. So the focus of my research with regards to PROMs is on the quality of life aspects and also on the longer term quality of life implications. So the figure on the right here shows the pattern of quality of life improvement following surgery. So patients typically have a significant improvement in their quality of life within their first year of surgery, and their effects tend to plateau in subsequent years. So although we know that this pattern of recovery is well known and it's common across most patients, but outcomes can differ between patients. So consequently, effectiveness gained from surgery can vary considerably across different patients. So as we know, that research has shown that up to 20% of patients with total knee replacement don't gain clinically meaningful improvement. So it might be likely that this average does not reflect the different quality of life trajectories for all patients. So PROMs can potentially provide useful insights into the impact of the intervention from the patient's perspective. So patient-reported outcomes such as quality of life have consistently demonstrated to be an important predictor of outcomes such as complications, hospitalizations, and mortality. So this suggests that a better understanding of patients' quality of life trajectories can reveal important information on disease progressions and outcomes. Patient-reported outcomes such as quality of life can also be particularly relevant to economic evaluation of interventions for a number of reasons. So firstly, they are used to calculate quality-adjusted life years, which are important measures of effectiveness and are commonly used in health economic evaluations. So it's basically this area under the curve here that you see that is shaded in blue that combines the morbidity and also the length of life. Secondly, the standard approach of economic evaluation is to treat patients as a homogeneous group, and their typically cost effectiveness results are presented as an average of the group with a given uncertainty. So on average, we know that total knee replacement is cost effective. However, it is recognized that patients vary in a number of different ways regarding the benefit on how they achieve from the intervention itself or in the cost of delivering it. So this average that we have may not be applicable to all patients. Thirdly, in economic evaluations, extrapolating beyond the study period or available data is often necessary, but there is limited guidance on how we should appropriately extrapolate quality of life, and existing methods rely on the use of assumptions in models. So assumptions regarding how we extrapolate qualities or future trajectories is important because this type of assumptions can have substantial impact on resulting qualities and cost effectiveness. So using the data from Smart Registry, I explored how we can maximize the data collected from real-world clinical practice to gain valuable insights in the variations in patients' outcomes, characteristics associated with different outcomes, and also to empirically explore the impact of quality of life when we extrapolate outcomes such as survival. I will showcase this in 3 different studies that I've worked on over the course of my PhD. So I'll briefly go through these in turn for the remaining of the presentation. So study 1, I used patient-reported outcomes extracted from the Smart Registry, and I employed latent class growth analysis to explore the variations in long-term quality of life outcomes. So in this study, I showed the important differences in long-term outcomes and the variations in the value of care, and also explored the potential use of patient-reported outcome measures to guide patient-centered care. So to uncover potential variations in quality of life outcomes, I applied latent class growth analysis. So it is a form of growth mixture modeling, a modeling technique that it can be used to identify clusters of individuals following similar progressions over time or by age. So as the number of potential trajectories is unknown, a series of models with different number of classes were estimated. Patients were then assigned to the trajectories in which they had the highest posterior probability of membership, and quality adjusted life years qualities for each of the trajectories were then calculated to quantify the effectiveness or the health benefit gain by the surgery. So after each of the quality of life trajectories and the subject membership has been determined, I then use multinomial logistic regression analysis to correlate the patient characteristics to the identified trajectories. So this slide here shows the results. So we find 6 distinct quality of life trajectories that was identified through this particular work. Which demonstrated the presence of significant heterogeneity in outcomes among total knee replacement patients. And it also shows that not all patients benefit from surgery in the same way. So with the table on the right, you see that I've calculated the qualities, and the incremental qualities represents the health benefit that was gained from the surgery itself. So it does show that there are distinct variations in qualities from the intervention, which does raise the question that if the particular surgical intervention is necessarily good value for all. And the second thing is that less than 1/5 of patients actually exhibited the ideal trajectory, which is the orange line that you can see on the screen, which is trajectory 5. The third thing is that 55% of the cohort actually showed poor quality of life outcomes with small health gains. So it is quite a substantial proportion of the cohort that exhibited poor health gains. So using the results from the multinomial logistic regression, I put together a table of patient characteristics associated with these trajectories. So it was with this particular table, it is hoped that by understanding the patient characteristics associated with these trajectories, we could help maximize the use of routinely collected patient-reported outcomes data to help facilitate shared decision-making and optimize patient outcomes. So for example, knowledge of the combination of the characteristics that predispose the patients to trajectories of poor health gains, for example, trajectories 1, 2, and 6, can potentially be helpful in anticipating possible outcomes or possible poor outcomes, and also mitigating the risk of poor outcomes. So I'll move on to the second study that I did. So recognizing that there's significant heterogeneity in quality of life outcomes among total knee replacement patients, I proceeded to verify this in this second study here, by examining whether quality of life trajectories differ between patients with diabetes and without diabetes. In this particular study, I used multi-level regression model to model the repeated measures of quality of life over time. And the two main contributions from this particular study is that it emphasized notable differences in the quality of life patients among patient subgroups. And it also highlighted the need for tailored post-surgery management. So multi-level modeling was used to determine whether changes of quality of life differed depending on diabetes status. And this approach was used in the study as it can account for the longitudinal nature of the data, and also to assess patterns of change of repeated measures over time. So it is a flexible method of modeling within cluster correlations, which means that it can account for the correlations between quality of life measures of the same individual over time. Time was then modeled as a categorical predictor to allow for the flexibility in capturing quality of life patients' patterns, and also to facilitate comparisons across time. The model included possible confounders, and these were and the variables listed on the screen are those that are variables that were adjusted for. So this figure shows the patterns of quality of life pre-surgery up to 5 years post-surgery of patients by diabetes status and also by sex. I found that even after controlling for confounders, patients with diabetes exhibited poorer outcomes following surgery compared to those without diabetes. And these differences were sustained over time. So despite both groups starting off at the same quality of life at baseline, results from the model indicate that patients with diabetes consistently report poorer quality of life and did not improve to the same magnitude as those patients without diabetes. There are also evident differences between females and males, and females consistently report poorer quality of life across the 5-year period. So I suppose these findings are useful in trying to help guide care among patients with diabetes, and also in facilitating discussions of expected outcomes and the impact of surgery on their quality of life. The sex differences in the outcomes also highlight that perhaps there is a need to consider if females with diabetes should be managed differently in order to maximize their outcomes. So the findings also do indicate that cost-effectiveness results based on the population averages may not adequately reflect the true value of the intervention, and perhaps more needs to be done to identify vulnerable populations to improve the value of care provided. So I'll move on to the third study. So my third study is a methodological piece where I examine the relationship between quality of life and mortality and its influence on survival estimates. I quantified the impact of unaccounted correlation on cost-effectiveness results. So there is a growing body of evidence that indicates that patient-reported outcomes such as quality of life can be important predictors of mortality. So this has been demonstrated in a number of chronic diseases such as diabetes, end-stage renal disease, pulmonary arterial hypertension, and also in the general population. So similar observations has also been found in total knee replacement patients. So these figures here show the Kaplan-Meier survival curves of the Smart Registry cohort that is split by baseline quality of life, which is the panel on the left, and those on the right shows the change in quality of life after surgery. So I'll describe the first one on the one on the left first. So the panel on the left shows that those with higher quality of life at surgery have lower mortality than those who, those with higher quality of life at baseline surgery have better survival rates than those with lower baseline quality of life. And the panel on the right shows that improvements after surgery also have an effect on mortality. So those reporting a positive change in quality of life after the surgery was found to be associated with lower rate of mortality compared to those who have deteriorated over time. So current health economic models rarely capture this particular correlation between quality of life and mortality when we extrapolate survival. And I suppose this is important because survival estimates are often translated into health outcomes such as life expectancy and QALYs, quality adjusted life years, to quantify health effects, which are important outcomes in economic evaluations assessments. So imprecise survival extrapolations can potentially impact on cost effectiveness results and could potentially misinform policy decisions. So to demonstrate the impact of quality of life, survival models were developed to assess this. And the survival models that I built were parametric models. And for simplicity, only sex and the relevant utilities were included in the model itself. So I won't go through too much in detail. Survival functions from each of these models were then used to estimate life expectancies and also to calculate QALYs. And comparisons across these models were then made to the reference model, which is the model number 1. So this table looks really busy, so I apologize for that, but I'll walk you through this. So this table shows the results from the analysis. It shows the estimated life expectancies and comparisons to the reference model. So for this particular presentation, we'll just focus on the right-hand side of the screen, which is model 4. So looking at the column for model 4, the incorporation of quality of life variables into our survival model has an absolute impact of 0.32 years and 0.53 QALYs. And this actually translated into a change in incremental effectiveness of about 9.5%. So although it might look small, but in cost effectiveness analysis, small changes in the denominator of effectiveness can potentially also have an impact on cost effectiveness results. So small changes can also have can result in different cost effectiveness results and can potentially impact on decision making. So I suppose the results from this study suggest that the inclusion of quality of life measures when extrapolating survival can influence outcomes such as life expectancies and QALYs. And the main implication this has for economic evaluations is that while there's been quite a lot of research pointing towards a positive relationship between quality of life and mortality, it is quite uncommon to quantitatively consider quality of life when we extrapolate survival. So potentially, this could be overlooking the possible correlation between the two. So current health economic models commonly extrapolate outcomes based on patient risk factors such as age, sex, comorbidities, and so on. And this may not completely capture the effects on survival. And it also contradicts the emerging evidence that that quality of life do have some predictive effects. So this is the last slide of my presentation. So to summarize, through the 3 studies, I do hope that I've demonstrated that there is real value in data such as patient-reported outcomes, and there is potential in translating such types of data to guide patient-centered care, and potentially it can be helpful in facilitating delivery of individualized care through greater patient engagement and shared decision-making to optimize patient outcomes. I've also contributed to the research literature through methodological research in trying to improve how we can model long-term outcomes in health economic models that are commonly used in resource allocation considerations. So thanks for listening to me, and I'm happy to take any questions.
Thanks, Michelle. I'll probably open up to all to ask any questions. So if you do have any, raise your hand and I can unmute you. We do have some questions that have come through the Q&A box. So I'll read out the first one that came through from Jay, and this was directed towards Nardia. Could you elaborate on what surgeons, GPs, nurses, or allied health professionals could do to modulate satisfaction in people who have negative thoughts or feelings or negative social and contextual factors? So A, prior to surgery, and B, after surgery.
I think it's difficult for me to comment on pre-surgery, so this would be purely speculative, but because obviously the study was retrospective. But potentially we could better use screening tools to account for people who do have negative effects, and potentially capture anyone who's struggling with their home environment or isn't participating socially. And maybe these can be addressed prior to surgery, so referral on to appropriate allied health, whether that be a psychologist or a social worker, or get them engaged in some community activity. After surgery, I think we could probably just use the conceptual model that I created in the second study with my supervisors, and use that to guide patient care if they are, expressing low satisfaction with their surgery. But I think this should definitely begin with just basic rehabilitation. So similar to kind of the GLAD program to improve pain and function outcomes, because from my interviews, I think that a lot of people didn't really get kind of appropriate support for post-operative rehab. It wasn't very personalised. It was in the hospital and it went over a short period of time. And then following that, if that doesn't work, we can use kind of those 3 mechanisms of change to help people adapt to their outcomes a bit better. Hopefully that answers the question.
Excellent. There is another question from Jay, directed at you, Nardia. So is there a way to screen people at risk of being dissatisfied before surgery?
Well, I think we could screen for people who have high levels of anxiety or depression. Potentially, I think this is an area for future research, but just indicated by the findings from this PhD, we could do that. And maybe, I'm not really sure about this, but maybe there needs to be some kind of assessment of cognitive flexibility if people have that ability to change their perceptions of a good outcome for them, because I guess sometimes you don't really know how they're going to go until after the surgery, and are they going to be able to adapt. But I think in a perfect world, we should really have everyone do some kind of GLAD program before they go into surgery to see if they will get a good outcome just from that before they do something really invasive like a total knee replacement anyway.
And before we do move on to Michelle, because there is a question directed towards Michelle in the Q&A, Michelle Chu had a question as well. Did you want to unmute yourself? And
Sure, thanks. Thanks, Nardia. That was a really great body of work and a great presentation. I guess my question is that, any ideas why the perception of there being no other options besides surgery is so strong?
I think it's just a social narrative. I honestly think that we've existed in a very medical model of care for quite some time, and particularly for that generation of people, it was definitely centered around if you have a problem, you go and see your doctor. And this notion of going and seeing any kind of allied health wasn't probably a thing that they grew up with. And so there probably needs to change that narrative, some kind of public health messaging around osteoarthritis being similar to something like diabetes, which is this kind of long-term management kind of thing, not just a quick fix with surgery. Because for some people, obviously, it's going to be an amazing result, but not for everybody.
Another question for Michelle. Well, the first question for Michelle. Some people with diabetes manage their condition well, while others do not. likely accounting for the wider confidence intervals for this group compared to those without diabetes. Do you have any data or thoughts on how well-controlled diabetes versus poorly controlled diabetes may affect quality of life post-surgery?
Thanks, Jay, for your question. That's a really great question. We did try to get some information on whether the patient's diabetes was well controlled or not through trying to by obtaining HbA1c data from patients' records. But unfortunately, the data that we've got was a little bit patchy, and we weren't able to collect enough information on that. So we wasn't able to subgroup it in that way to see whether patients were well controlled or not poorly controlled diabetes affect their post-surgery. So yeah, potentially that will be an effect that we could observe. But yeah, unfortunately, we do not have enough data to answer that question sufficiently.
Right. And there's another comment and a question from Sam Bunsley. Congratulations, Nadia and Michelle, on these excellent bodies of work. As two high quality Opus PhD students, what words of advice or top tips can you share with our students in the earlier stages of their PhD journey? Does anyone want to go?
I'll go first. What is my advice? I think particularly for the way that a lot of students are doing a PhD now, which is kind of at the beginning of their research careers rather than the end, it's okay to not know what you're doing and to get things wrong. I don't think your supervisors expect that for you. Particularly for me, I came into this PhD as a physio. I didn't know anything about patient-reported outcome measures, never done any qualitative research, so it was a big learning curve. So I think it's okay to approach it like that. I also think it's quite healthy to treat a PhD like a job, which essentially is if you're on a government scholarship. So don't let it consume you if it's not going well, if you get rejected from journals, it's just sort of part and parcel. And under that kind of job sort of conceptualization of PhD, make sure that you continue to do things outside of your PhD that you enjoy. So see your friends and family, do your sport, whatever it is, in the same way that you would if you were just working a full-time or a part-time job. And obviously your supervisors are amazing resources. We have some incredible supervisors at Opus, so they're going to be really supportive of you, and they know everything, in my opinion. So if you have any problems, I'm no doubt that they will help you along the way. That's it.
Thanks. And Michelle?
I guess I would echo what Nadia has said about the supervisors that we've got around us. They're incredibly supportive, and I've really enjoyed working with my supervisors as well as other colleagues within the Opus CRE. So it's been, I think that played a big part in making the PhD journey a little bit less painful and bearable. So that was definitely helpful. So surrounding yourself with supportive group of people. I guess one of the things that fellow PhD peers have told me, I have constantly reminded me from the start of my PhD, is that this entire journey is a marathon and not a sprint. So it's okay sometimes, that if you feel like you're not progressing well enough, or you feel like you're unmotivated, or you feel like you've done heaps, but you've got nothing to show for. I guess, yeah, just trying to bear in mind that it is a marathon and not a sprint. So you are doing this PhD to really learn something, and you should take the time to sit, properly learn it. And, and everyone learns at different paces, and everyone works at a different pace. So yeah, so just don't be too deflated or unmotivated if you feel that, you feel that you haven't done enough. And you might be surprised though, if you have a network of PhD peers with you, if you guys openly talk about it, you might be surprised to find that actually we're all feeling the same way. We're all in the same boat. So sometimes just talking about it could be helpful.
Excellent advice. Does anyone have any other questions about PhD or about their work? You can raise your hand through the button at the bottom. No, nothing? Okay, well, we're nearing 1 o'clock, so we might just end it there. Thank you very much for tuning in, everyone. Thank you also to our panelists for also presenting, and also congratulations. It's an exciting feeling getting across the finishing line, especially for you, Michelle, and Nadia, you will be getting there very soon. So you'll be able to celebrate and choose all the different colors for the binding. That's exciting. Excellent work. Thank you very much, everyone. And we'll join you again for another webinar, hopefully scheduled for next month. We'll be updating our website and also sending out mails just to remind everyone. Thank you, and we'll see you next time.
Thanks. Thanks,
Thank
Michelle.
you. Thanks, Michelle.